Good morning, everyone. Nice to meet everyone on the 19th of October. Last week was World Mental Health Day, and the focus was on making mental health a global priority for everyone. So I'm delighted that we're all here today to listen to some of the work, fantastic research that's going on, also some of the work of CME as well. So this is a joint meeting with the Scottish Rural Health Partnership, University of Highlands and Islands, and the National Rural Mental Health Forum. So Professor Sarah-Anne Munoz will be convening the parts where we're listening to the research of Hereward Proops and Martin Malcolm. And in the middle we'll have CME as well. The National Rural Mental Health Forum was set up about 6 years ago to tackle mental health in rural parts of Scotland, and we have about 230 membership organisations from third sector, public sector and private sector. And since COVID we've had similar meetings to this forum meetings, and we'll give you a link later on to where you can see some of those. 36 so far, so this will be the 37th, and I think including this one getting on for 3,000 registered attendees. So really glad to see everyone today to look at mental health, some of the research and some of the good work by the likes of CME. So without further ado, I'll pass you over to Professor Sarah-Anne Munoz of the University of Highlands and Islands. There will be chances for questions. You may have to use the chat function for that. I will have to say that this is being recorded and will go up on the Scottish Rural Health Partnership website as well, so we can share that with you. And there will be a little survey at the end too. So Sarah-Anne Munoz, over to you to say a little bit about the Rural Health Partnership and introduce the first speaker. Sarah-Anne.
Thanks, Jim. I'm afraid I'm not able to get my video to work, so I'm not sure if we can resolve that. Neil might be able to help with that just now. Otherwise, I will just continue. Okay. Oh, there we go. Great. Thank you very much. So thanks, Jim. Yes, I'm Sarah-Anne Munoz. I'm a Professor of Rural Health at UHI, member of the Scottish Rural Health Partnership. So I'm standing in for Professor Sandra McCreary this morning, who unfortunately is unable to join us. But just wanted to thank everyone for joining on behalf of the Rural Health Partnership. And particularly all the speakers and attendees. So I'm sure you're aware that SRHP is a membership organisation, so it's open to anyone with an interest in rural and remote health and care, hosted by University of the Highlands and Islands. So we're just delighted to be able to co-host the webinar this morning. And as Jim said, our first speaker is going to tell us about some innovative research which has been carried out in partnership between UHI and SRHP. And so Hereward Proops is going to speak first, and he's a lecturer at the UHI Outer Hebrides, and he's been working with colleagues within the Division of Rural Health and Wellbeing here at UHI on a rural mental health study, so he'll outline that for us this morning. Hereward's got a background in teaching pupils with additional support needs and is an accredited psychotherapist and counsellor. So he splits his time between private therapy practice and lecturing at the college. So Hereward, I'd like to invite you to give us the first presentation of the morning.
And Sarah, and I think you'll have to make Hereward the next the host. So pass the parcel so he can put his camera on. Thanks.
Okay, let me see. I can't put it on just yet. There we go. Hopefully you can all see my beautiful face here. Thanks so much for having me here today. My name's Hereward. I lecture at UHI Outer Hebrides. I am module leader in child and adolescent mental health. and I also work as a psychotherapist in private practice, working with adults and children and young people. This is a really interesting piece of research that I'm going to share today. I'm just going to share my screen and hope that this works. There we go. So Jim, that's working? Okay, good stuff. So this is the Delphi method workshop. To introduce it, I'll talk about how this sort of research came to be. 2 years ago, we had the first International Rural Mental Health Conference in UHI Inverness. And there was speakers from Texas A&M Kingsville University, Dr. Steve Bain and Dr. Christopher Garza, and they were presenting their work using the Delphi method, or the Delphi method, as they like to call it. And this is, they were presenting it as a means to engage community members to identify potential solutions to community identified needs. Traditionally, the Delphi method is used as a kind of workshop event where experts get together and discuss the topic. What's interesting about this this approach that they took is they deemed that because they're talking about community mental health needs, the experts are therefore members of the community. So this was the idea behind it when they ran it in Texas, was to get local people to talk about what mental health meant for them and the needs that they felt were in the community. And what could be done about it, what could be done for mental health in the community. I'll go on. I'll give you a little background on the Outer Hebrides, because I'm aware I'm talking to people across Scotland. So we have a relatively small population here, but dispersed over quite a wide area. This is data that I've used in another presentation where I'm talking about children and young people in the islands. As you can see, 15.6% of the population are children and young people under the age of 16, although deaths exceed births, and there is and continues to be a pretty steady population decline, people leaving the islands. I'm not born and bred Lewisman. I am from Birmingham originally. And so I think it's always interesting to compare the population density. Now, according to the 2011 data, that was the most up-to-date I could get hold of for population density. In Lewis, it's 9.65 people per square kilometre, compared to my birthplace of Birmingham, where it's 3,649 people per square kilometre. So it gives you an idea of how geographically dispersed the population is here in Lewis. Okay. Another issue facing the islands is poverty, in particular fuel poverty. 36% of all Outer Hebrides households were experiencing fuel poverty. That was back in 2020. Obviously, with the spiraling cost of living crisis, this is going to be worse now, probably significantly worse. But that is, again, quite a concerning statistic. So onto the background. As I said, this was developed by Steve Bain and Kelly Hall, Texas A&M Kingsville, to engage rural Texans, understanding the problems and identifying potential solutions to meet mental health needs. I listened to their talk 2 years ago, and at the end of the talk, they said, any questions? And I stuck my hand up and I said, can we repeat this in Scotland, please? Because I think this is fascinating. I think it would make a really interesting kind of comparative study, and it would be, I think, a valuable contribution to our kind of knowledge base. I'm thrilled to say that Sarah-Anne got on board with it, because she's really the expert in research here. And so we got it going. Unfortunately, we weren't able to do it the year we wanted to do it due to COVID. So it's kind of been delayed a little bit. We ran similar workshops in Stornoway, in the Isle of Lewis, the Outer Hebrides, but also in the Black Isle. I'm going to be focusing today on the Stornoway workshop because that was the one I was involved in. There's a lovely picture of our buffet. I'm very proud of the buffet we had for this event. I think that was a huge success. So when we set up, obviously Sarah-Anne and Liz Ellis put forward the proposal and did all the fiddly stuff with the ethical review and things like that. Myself and Dr. Rachel Erskine recruited locally via social media, the local press, and personal contacts, as in university contacts and things like this, looking for people who would be willing to take part. Another thing we organised was this lovely buffet done by our college catering department. It was really handy to have them on board because we got a fantastic amount of food. And we offered our participants, in fact, we didn't offer them, we didn't tell them it was only on the day, we gave them a local shopping voucher as well for thanks for taking part, because one of the difficulties with the Delphi method is it's quite a lengthy piece of research. It takes up quite a lot of the participants' time. It's basically a full day. We held it at the college, which is a nice accessible venue in Stornoway. Everyone knows where it is, and there's good public transport links to get there. So how does the Delphi method work? Well, it's the experts in this case are people in the community, as I said. So we gather the participants together and we split them into groups, and each group is presented with 3 questions, and I'll show you these questions in a moment. And as a group, they discuss them and come up with ideas in response to them. The facilitator, which in the Stornoway case was myself, Sarah Bradley and Liz Ellis. Liz and Sarah each took a team, and so they were facilitating for the groups, and I acted as the main facilitator when we were discussing as a whole group. So the participants would discuss the questions. There was no input from the facilitators. It was not about our opinions. It was not about our feelings, and it was very much what do the people in the community say about this. So our role as facilitators was merely to kind of acknowledge what they were saying and help summarize the things. Once each round was done, so we do a round on question 1, then each group facilitator would feed back to the main facilitator, myself, and we'd kind of have a big kind of whiteboard where we'd be noting down all the different things that had arisen in both groups. We did this several times, going back and forth and discussing as in small groups and larger groups as to what our answer as a whole group of experts would be. So it's a kind of a discussion, and through discussion we're seeking consent and a kind of co-creation of an opinion by the whole group. And one of the things we were very, very careful about is we had to have the agreement of the participants. They had to agree that that was the best statement we've come up with. Our participants, there were 7 male, 2 female. We had actually hoped for more participants. Unfortunately, 1 or 2 pulled out the day before. I think we were aiming for between 12 and 15 participants. We ended up with 9. A couple pulled out a couple of days before, and I think 3 of them just ghosted us and didn't appear at all, which was a bit of a shame. But with 9 participants, that was enough to run 2 groups. I think ideally we'd have liked to have had 3 groups running at the time. The age range was between 23 and 62, an average of about 40.67. 3 were employed part-time, 4 were full-time employed, 2 were unemployed. Interestingly, 3 were employed by the local authority, and that's quite a large representation by our local authority. But actually, if you consider that it's the biggest employer on the island, it sort of makes sense. We had 1 working in care, and we weren't sure whether this person was a local authority carer or a private carer, so a bit of a question mark over that. 1 worked for the NHS, 1 in education, and 1 was a third sector worker. The research questions were as follows. The first question, and sorry, these are exactly the same questions that were presented to the participants in Texas as well. So this was the part that was very similar to the Texas method. What does mental health mean to you? The second question was, what are the biggest mental health issues or needs you see facing this community? And the third question was, what solutions would you suggest that would meet the mental health needs of your community? Obviously, we spent a good hour and a bit discussing each one of these questions. So there was a huge amount of back and forth and collaboration and seeking consent, seeking agreement from the participants. The eventual statements that we came to and agreed upon were actually lengthier than the statements that our Texan colleagues had. The Texans, I think, were a little bit more concise in their summing up, but there were some really interesting findings in the statements. So I'm going to share them now. So the first question: what does mental health mean to you? It said, mental and physical health are intertwined, but physical health is viewed as separate and easier to treat. Mental health is a broad term, often with negative connotations and perceptions. It can affect people directly or indirectly. A lack of understanding leads to depersonalization, shame, fear, and stigma. We were quite, I think myself, Liz, and Sarah were quite taken aback by the negativity that arose whilst discussing mental health. A lot of the words that were being sort of bandied around in the discussion were quite negative, loaded terms: instability, loneliness, stigmatization, fear, shame, lack of connection, being invisible. But it was quite interesting to hear that people were aware that mental health is not necessarily always a negative thing. It is simply, something we all live with. But one statement really stuck out for me was, living the best life you can is the ideal, but not necessarily the reality. Another one that came up quite a lot was this issue of depersonalization, which we'll come back to again. I think this is for me, this is quite a concerning one, in the sense of feeling invisible, feeling unheard, and not having the individual needs met. So that was the first statement I came up with. The next one was, what are the biggest mental health issues or needs you see facing the community? This part of the discussion was very interesting. There was some really passionate responses from the participants, a number of whom had experiences seeking support for themselves or seeking support for people close to them, family members or friends. And there was quite a feel of people being let down by the system, but also an awareness of the challenges facing the community and facing the services that are providing for the community. The difficulties of funding, the difficulties the NHS faces. So the statement was, there are multiple issues regarding mental health facing the community. A resistance to change in the wider community stems from a lack of understanding and compassion. There is no parity of care when comparing mental health to physical health. There's a gap between what the community needs and what statutory services, such as the NHS social care, can provide. Issues with recruitment and retention mean a lack of professionals working on the front line. A reliance on locums leads to a lack of continuity of care. As a result, there's a lack of early intervention, no crisis care, and no out-of-hours services. Locals attempt to fill this gap with third sector community groups, but this raises challenges of training and funding such groups. So that was the findings for that one. What solutions would you suggest that would meet the mental health needs of your community? This part felt much more hopeful, and the participants clearly knew what they wanted to see. And I'm going to say, obviously, a lot of this is going to be blue sky thinking. Not all these things are immediately achievable, but I think at the heart of it is there's a desire to see things, and whether they're the NHS or community-based, properly staffed and funded. And I think this raises the eternal question, where's that money going to come from? So the statement the group came up with was a proactive rather than reactive approach is needed. Co-production of services will enhance personalisation. Community compassion and a will for change, along with education at all levels from school age onwards, can raise awareness and reduce stigma. Quality, consistency and continuity of statutory services will ensure excellence in care, which can then be complemented by third sector community groups and peer support. Such complementary services need to be fully resourced and supported. Ongoing community-based research can inform policy and practice, ensuring needs continue to be met in the community. So this, as I said, is a little bit of blue sky thinking. It's a little bit of what we would like to see and what the participants would like to see in the community. But it does raise some really interesting points. And one of the points was about community compassion and a will for change. I think it was very important. Education became quite an important thing. And obviously we have the curriculum for excellence, which places physical and emotional well-being at the heart of the curriculum. And this has been running for over 10 years now in Scotland. And I think in my experience of working with children and young people has been quite successful. I think children and young people in Scotland are more clued up on emotional well-being and mental health issues. What the group was saying is that's great for the young people, but what about for the adults? What about for the adults who have grown up with the stigma around mental health? How can we support and provide education for people within the community? I think the other main point that was coming out of this one was the statutory services ideally would be doing the frontline work and be supported by third sector and community groups, whereas a lot of our participants felt that it was the third sector and community groups that were doing a lot of the interventions at the sort of subclinical level, which is of course how things work at the moment. So the implications of the findings, there is stigmatization of mental health, and the participants felt that there is still quite a large amount of stigma towards mental health. They were very critical of current services, in particular a lack of the continuity of care and an over-reliance on locums, which is something that was raised several times. The depersonalization, as I said, this was a real surprise to me. I didn't expect to see this, but in the age of person or patient-centered practice, the feeling that they are just a statistic, the feeling that they are not being heard, not being seen, that they are kind of invisible, I think is quite concerning. A community-based response was wanted, and they felt it had to be preventative rather than reactive, and this would require a kind of systems change. And at the heart of that would be mental health education for all, not just for the schools, but for communities as well. And of course, in order for this to happen, we need these things need to be better funded. So the study was repeated in the Black Isle. I'm not aware at the moment of the results. I know there were fewer participants there. I think ideally we would really want to repeat this in other rural locations, and I certainly would be interested in repeating it in Lewis with a larger cohort of participants to see if we get the same results or different perspectives. And for me, I'd really like to hear a little bit more of the experiences of frontline NHS staff, frontline social care staff, and third sector workers who are working with mental health issues in the community, and to see if what their ideas for change could be. So I'm conscious of the time, so I'm going to wrap it up there and stop sharing my screen. There we go.
That's super. Thanks very much, Hereward, for taking us through. We've got some time now for a few questions. If anybody has any questions, you can type those in the chat just now, and we can have a look at those. So a couple of the points that have come up already, somebody was saying it sounds similar to deliberative dialogue, which is another method, not one that I've used. I'm not sure, Hereward, whether you have either, but
I've not, no.
yeah, I mean, I would agree with the person that's raised that. Obviously, I think with this method, there's not the same kind of looking at the evidence base and introducing the topic as I think there would be with deliberative dialogue. I think the thing about this method that you've described is that it really emerges from the conversation that the community members are engaged in. Really, that's the basis of the findings and the dialogue. I think one of the things that's quite novel about it, and I guess that was being tested here, is that it moves towards some kind of consensus building. So I don't know if you could reflect on how that went, Hereward. Was that something that was experienced positively by the participants? Was that a tricky element, or is that something that could maybe be positive about this approach and replicated elsewhere?
I think it was really interesting. I mean, the majority of the participants did not know one another. I think there were only two pairs of people who came to the workshop that actually knew one another outside. So it was sort of, I think initially there's that awkwardness of when working with new people. But once people got going and once people got discussing, and as I said, it was a really, really passionate discussion. And I think it's always really interesting to kind of listen in and facilitate those sorts of things. There were some very, very strong opinions voiced. That was one thing I can say. It was really strong opinions voiced. And I think people largely did agree with one another. When there were differences of opinion, it was a case of getting each participant to kind of listen to one another and hear the other person's perspective and things like this, and then working it into working those differences of opinion into the into those statements that the group came up with. But I think actually largely as a kind of co-creative experience, the participants were in pretty strong agreement with one another for the most part.
That's great. Someone else was asking about like who designed the questions, so the kind of the methods, etc., that went into it. So yeah, do you want to?
Those were the questions themselves were designed by Steve Bain and his colleague at Texas A&M Kingsville University, because we were replicating the study that they did. And I think, as I said, the responses that they gathered in Texas were much more concise than ours. But we haven't yet had a real chance to sit down and do a kind of comparative study of the two things. But thinking back to the presentation that I saw from our Texan colleagues, there was certainly much more passion presented in our findings. I think our participants felt very, very strongly about these things. So yeah, that's where we are with it at the moment.
Can I just chip in? There's a question and answer, a Q&A part. There's some questions in there, and there's also some questions in the chat. So there's two ways of asking questions. It just so the Scottish Recovery meetings have got a question in there as well. Sorry, Sarah-Anne, just a new system.
No, that's perfect. Thank you. I can see that. So yep, so Scottish Recovery meetings are saying, could community CLD workers, I would say community link workers, but I'm not sure what that is, within the local authority support the mental health learning in the community for adults? Yeah, there's a couple of other questions as well. How important was it to have effective facilitators?
Yeah,
yeah.
that was the really important thing, because as I said, we wanted to present everyone that participated. We wanted all of their views to be heard. And I think there were a couple of participants who were much more vocal than others. So there were points at which we were trying to encourage the quieter participants to share their thoughts and feelings and things as well. So I think the facilitation of it was really important to ensure that everyone, every participant's opinions were being were listened to and acknowledged and contributed to the discussion as a whole.
Yeah, absolutely.
There was a point there about adult adult mental health things. Now this isn't strictly linked to this piece of research, but I'd just like to say, in my own experience, in the past few years, I've done a number of mental health talks around community groups aimed at adults here on the island, and unfortunately then generally not very well attended. And I think this is one of the real difficulties if we're looking at kind of adult education and sharing these things, is as adults we're all busy. You know, everyone's got jobs and families and things going on in the evening, you know, driving the kids to different events and stuff like that. So I think one of the challenges we face is, if we are looking at community learning activities, community education, of disseminating knowledge about mental health and helping people get a better understanding of it, how do we do that effectively? Because as I said, not everyone is able to come to these things or has the time to come to these things.
Yeah, I think that's a very good point. Someone else has asked whether the results from Stornoway in Texas can be shared. So yeah,
well, we're
working on that.
We're working on that.
Yeah.
It's not yet been published, so these are just our kind of really we're just sharing the kind of the statements here today. I think this is the first time we've kind of publicly shared them. Is that right?
Yes.
Yeah.
And we can certainly share the presentations that have been done previously that you mentioned from the conference. And yeah, when the reports are written up, then that will include the findings from the Black Isle as well. So definitely can be shared. Yeah, that's great. I think someone else is asking as well, like in terms of linking with the third sector, like how could the third sector be part of maybe what we're doing going forward, and what would be the best way to communicate with those third sector organisations?
I think that the third sector is going to be hugely important, and I think community groups are going to be hugely important as well. And it is not just mental health is not just the NHS's responsibility, and you know, I think a lot of the approach that's used is a lot of the subclinical work is carried out by community interventions, by third sector groups. On the island we have a counselling and family mediation, it's called, which is our third sector mental health and there are a number of other mental health groups active on the island as well. I think coordination between the different groups is really, really important. If you have a lot of different disparate groups doing different things at once, somehow being able to make links between the different organisations and communication between the different organisations and the NHS itself, I think, is a really, really important factor in that.
That's great. Thank you so much. So I think we'll definitely let everybody know as the materials become available. Yeah.
Sarah-Anne, can I just chip in? Sorry, our third presenter today looks like he's having IT issues with NHS, so he may not be able to come in. So there's quite a lot of questions still going on. So we could give Hereward some more time, Sarah-Anne. I hope that's okay with our next Lindsay as well. That'd be great. I don't want to stop a good conversation. There's lots of good points coming out there.
Yeah, sure. So I think if I just have a look at what we've not covered, I guess following on from that discussion around third sector, someone else has asked you, do you feel that the third sector services were visible to the NHS, and if there were systematic barriers to signposting, and perhaps continuity of statutory staff? So I think those are some continuity of care was probably one of the things that came up in the Black IO workshop that I was part of as well. Hereward, was that something that you covered? Yeah.
Continuity of care is really challenging, and obviously I don't really want to speak for the NHS here because I'm not employed by the NHS, but one of the things that arose from our participants was that they felt that a lot of the time they would go and see someone and that person might be a locum, and again the locum, they might be on the island for a month, they might be on the island for a year, but the feeling that the participants said was that they don't have necessarily a vested interest in the community of the island. They're there for a bit and then they're going to go again, and because of this, I think it's challenging for the person who is seeking support to open up to someone. As a therapist, part of the work I do is the relationship with my clients. So it's building that relationship over time, and I think if every time someone goes and sees someone, it's a different doctor or a different CPN or a different locum or whatever, it makes it hard for that relationship to be established, if that makes sense.
It does, absolutely. And I think that maybe related to that as well, someone else has raised around online help, and whether that was something that we talked about with the community members, the question being kind of how did the community perceive those options for online help for mental health?
Yeah, it was discussed, and there are a number of online tools and means to access kind of support. One of the participants I remember had been through it all and had felt that none of that had been particularly useful, whereas other participants were a little more kind of positive in their things and saying, well, these things are useful and there's some useful advice and there's some useful guidance and things like that on these sites, but they felt that it can't be everything. There needs to be that that face-to-face kind of contact as well.
Oh, sorry, you're on mute, Sarah-Anne. Sorry, Kate Boyd's been asking a question in the webinar chat.
We just tackled that one, I hope.
Oh, sorry, that's fine.
No, it's fine. It's fine. I'm trying to keep up with
Yeah, so yeah, I'm looking at the questions as well. So Kate, yeah, I think the mindfulness courses and things like that largely were viewed as useful and useful resources, but I think it's one part of the bigger picture, if that makes sense.
That's great. Okay, I think, Jim, are you going to introduce the next speaker for us?
I can do. I think with the questions and answers, if there's not any of the questions been answered, then Hereward, if you're happy to just look at them and pop an answer to them.
Yeah, there's one I'd just like to address, and the issue is the issue of co-production and the fact that the questions we asked the participants were not part of that co-production thing, and I can certainly agree that, you know, that is I think it's mentioned, it's rather a top-down approach, as in, you know, we the researchers are coming up with the questions and putting it to the participants, rather than the participants coming up with the questions themselves. This was aimed at kind of replicating what was done in Texas. So we were starting with their questions. I know one of my colleagues, Liz Ellis, is actually really interested in co-production. That's part of her thing. So when she was facilitating the discussion, that was a big focus of hearing people's responses to it. I honestly don't know how we would do it if it was to be the participants coming up with the questions as well. I think that would make it much more challenging to facilitate. So I think that would be a different piece of research.
I think there's different views on that, and it's good to have those different views be explained there. So thanks for that. As I said, keep the conversations going in the chat and the question and answers. And Hereward, if you're okay to just have a glance over the chat and the questions, just to make sure we've copied anything. You can also you can carry on the conversations in the chat and the Q&A even. Which is fantastic. So thanks very much for that, Hereward. But before you do that, could you make Lindsay Crawford host?
I certainly can.
She'll be able to share her screen.
If I stop my video,
you click participants, and then you'll see.
Yeah, and I'm going to make Lindsay. There we go.
Brilliant. And Lindsay can now share her screen, and I'll make a quick introduction to Lindsay. Lindsay Crawford is from CME. She's an improvement officer with CME. So thank you very much for coming along. CME, I think many of you will know, it's a well-known brand and a great organisation tackling the stigma of mental health. And of course, Lindsay's going to talk today about a programme of support for employers that are committed to creating working environments that are inclusive of mental health and free from stigma and discrimination. We've heard about stigma today. We know it's on the decrease, but a long way to go yet, Lindsay. So job started, not finished. So Lindsay, thank you very much for coming along today, and we really look forward to your presentation. And as I said, we do have a bit more time than we thought due to the last presenter struggling with IT. So Lindsay, over to you.
Great. Good morning, everybody. I'm just going to start by first caveating today. I only found out at 10:22 today that I was presenting, and I haven't seen these slides, and so I've just been going through. So I do apologise if there's a few things that come up today that I'm not able to answer or I'm not familiar with, but I will go away and ask colleagues for clarification and come back to you. Absolutely. Let me just get myself sorted. There we go. I hope everybody can see that all right. Give me a little yell if you can. I can't see any chat questions, but I will come back to them at the end. Thanks, Jim's giving me a thumbs up there. So I'm here today to talk a little bit about CME and work, but as I said, I wasn't supposed to present today. A colleague, Rachel Bothling, was supposed to present today based on our new CME and work portal. and I'll take you through a little bit about that today. So first, obviously, Jim had said we're all very familiar with CME, but if there's anybody in the forum today who's not, CME is Scotland's national programme to tackle mental health stigma and discrimination. We've been around since 2002. It is actually our 20th birthday in October. It is October, so in a couple of weeks we're having a small celebration. Obviously, as well, I caveat that word celebration, because in a dream world we wouldn't be needed. We would have achieved our goal of, you know, a Scotland free from mental health stigma and discrimination. We are funded by the Scottish Government, and we're managed by the Scottish Association for Mental Health and the MHF, which is the Mental Health Foundation, and that's our research partner. And I believe next month my colleague Caitlin is going to be joining the call and taking you through some of our Smith's research, which is the Scottish Mental Health Illness Stigma Study, and it's a really powerful piece of research, and that will bring, I think, more of where our focus as CME is going in the next few years to life. But I won't talk more about that, but as I said, that's for your next forum meeting, I believe, in November. So a little bit about the CME staff. We are quite a small, but as I always like to say, a very mighty team. We work kind of across 3 kind of areas, settings, which is in my team here. We focus around education, workplaces, which I'll come on to in a minute, and then health and social care. We also have our community and priority groups, so we work around with populations such as Phoenix, LGBT health, so we work with the population or the Scotland at large to tackle stigma. And then of course comms, and that's our big piece. A lot where CME started was around campaigning, raising awareness and highlighting what's been going on. So there's a wee infographic up so you can see that our website is our website has all our details and all our contact information as well. If you're looking to, you think, oh, you know what, I have some comms ideas, and you maybe want to go directly to Nick. We're quite an open team. And as I said, it's very small and we cover all of Scotland, so we've got a lot of work to do. So CME and work, what is CME and work? Some of you may be familiar with CME and work. It has been around for a few years, but I'm bringing it today to talk a little bit about our new development, which is the CME and work portal. So let's first cover off what is CME and work. So it's to support employers to create the conditions for working environments that are inclusive of mental health, free from stigma and discrimination. It's a 4-step process. It's really facilitative, interactive, and it's taking people through. It's not about us coming in and doing something to an organisation. It's about people out there who are looking for support, who are looking for ways to make changes, but not necessarily sure where to go about how to go about it. It's really a framework if you want to hang your hat on something to go through a process. And we've had this CME work for quite a while now, but as I said, we're moving it electronically. So before it used to be a bit more clunky and we'd have a lot more going to employers, but now we're hoping that it's a lot more accessible because it's available online. So there's 4 stages. The needs assessment, so we carry out a thorough needs assessment of the workplace, including a self-assessment, online survey and additional focus groups. So we talk to staff via surveys, all anonymous of course, and if there's anything else that we're looking at, we'll do focus groups as well, which will give some of that rich experience. But you know, that's the big first step. Getting a feel for what your employees say is a really key thing, or what your colleagues say. Then of course from that there'll be some areas or there'll be some issues that will be presented from the assessment. It's the way that the portal is set out, it highlights those pretty quickly, so that then creates an improvement plan, and then you can target those areas, and there'll be lots of ways that you can do that. And a lot of people have lots of ideas, or it'll already be in people plan, HR plans, or you know, just ideas about employment in general that you've already got, but this will give you a bit of an impetus to see where they connect back to and where, so you can see hopefully where the issue is, what you could do to remedy it, and then obviously at the end you redo your evaluation and you see where the distance travelled is from the initial survey. So of course implementing the improvement plan takes about 18 months. And of course, during that time, we are available to support employers, but we're hopeful that the portal gives lots of prompts and lots of information in order for employers to kind of do it themselves. As I said, CME is quite a small team and we've got lots of resources online to support people when they're making these improvements. So I have covered over and what really Rachel would have been doing today is sharing a look at the portal, but I've had a few tech issues and I've been unable to get in this morning. I've got a few login issues, so what I'm going to do is I'm just going to share a small video with you which covers over a little bit more in detail, and if there's anything that I have missed, which I'm sure there has been, it will come up. So just give me 1 second and I will share that just now. There we go.
Lindsay, I don't think the noise is, so the sound is coming through. When you share screen, you might have to stop sharing screen. And if you share screen and then there's a little box says share your computer sound just before you do that. So if you stop sharing, and then click. Yeah, sorry, Lindsay.
No worries, apologies everybody.
It's okay, take your time. It's a very small little box on my computer. It's the bottom left hand side when you click the.
Yeah, here we go. That should be it. 1 second. Let's try that again, hopefully.
What is the See Me in Work portal? Research tells us that stigma-free, mentally healthy environments create cultures where people can flourish, help retain staff, improve the reputation of the organisation, and help achieve goals. The See Me in Work portal helps create this culture by supporting employers to take action to tackle mental health stigma and discrimination at work. The See Me in Work portal is a self-service digital platform that guides workplaces in Scotland through improvement cycles, reviewing their culture, practice, and policies. Each improvement cycle has 4 stages. Stage 1 involves carrying out a needs assessment of your organisation, self-assessing your workplace against the 7 key building blocks for creating stigma-free workplaces. 1. Senior leadership commitment and engagement. 2. Conditions for safe, effective and pertinent disclosure. 3. Mental health awareness and literacy. 4. Effective mental health training approaches. 5. Confident and informed line management. 6. Effective implementation of reasonable adjustments. 7. Stigma-free organisational culture and ethos. A survey and optional focus groups will help your organisation gather staff views across these areas too. All the information comes together in a needs assessment report, where your organisation can see the areas they are doing well, those that need some work, and where immediate attention is needed. Stage 2 is improvement planning, where all the information from the needs assessment report is used to suggest improvement actions and give advice on what success looks like. Your organisation can also consult staff on the improvement plan and add further actions. At Stage 3, Improvement Implementation, your organisation will deliver, monitor and evaluate the activities set out in the improvement plan. Stage 4, Evaluation and Review, is all about reflecting. What did you plan to do and what actually happened? Your organisation can then take this learning into the next improvement cycle. Your organisation will also be able to request a support call with See Me at various stages. Workplaces going through the programme can also become See Me in Work partners, an acknowledgement of their commitment to ending stigma and discrimination. Make your workplace the best it can be. Join the See Me in Work programme and become part of the See Us movement to end mental health stigma and discrimination. Find out more at workplaceportal.seemescotland.org.
There we are. That said it better than I could say it there. So that covers over a little bit, and it showed you a little bit around what the portal settings look like. I said it's quite an interactive portal. We're not looking for it to be really, really hard. It's not a trick. It's not supposed to be extra work. It's supposed to actually make things slicker for employers. I've got a couple more slides just to share with you before we go on to some questions. There we are. So I've covered over the portal, and I guess one of the key things about joining the programme, and as was said, is it is a big ask. We appreciate that, but it's a marathon, it's not a sprint, and we're asking for longevity. We're not going to get it right overnight. We've been working with some employers for years, and by the time they come around to their second cycle, there's even more things that they want to do. I think the key is that we want people to be engaged and be aware of what's going on as I said, you're not going to solve it overnight. You're not going to maybe see some of those improvements in the first instance. It might take a few years to embed. We're going for that bigger culture piece, and that's a really hard thing to sort out. So as I said, the 4 kind of key commitments we're looking for as covered over with senior leaders must sign off the work. So we work with a lot of people who are maybe got the appetite, they're maybe working in HR, got a work around equalities, but their senior leaders are not bought into it. And we try our best to support people in convincing their senior leaders to get on board, and I'll come into that in a wee second. But it has to be a senior leaders, it has to be leaders from the top driving improvements. It can't work if someone's going to be putting all that effort in, but they have very little ability to make changes. And that comes on to, we have to have an executive sponsor, so a director or a board member or someone with authority in the organisation to take responsibility for it, because it is a big piece of work, and it has to be done justly. As I said, organisations take 18 months to go through the cycle, and it is a big buy-in. So do they have the next 18 months? What's coming up in that time? Or there's other business things that's going to make it difficult to fulfil that? So when is the right time? We have that conversation with a lot of employers. So obviously COVID was not a good time to be doing an awful lot of improvement, but post-COVID we're getting more and more people coming to us saying, there's a lot of changes of the way that we work. So this programme, Senior Work, is really good for seeing where we are and where we want to be. And then, of course, organisations must be headquartered in Scotland. That's all to do with CME as a programme. As I started off, CME is Scotland's national programme, so we're particularly interested in Scotland. But also as well, we have colleagues in mind, Time to Change Wales, Inspire in Northern Ireland, and of course we've got a global anti-stigma alliance. So there's other organisations out there that can help you. So we want to focus on Scotland in particular. So people do come to us who are not headquartered in Scotland. We do send them elsewhere. So I just want to jump to building the case. As I talked about earlier, we do help employers to build the case. There we've got our cost calculator on our websites, and we may be familiar around this. So it shows how the cost of mental illness on your organisation, of course, it's estimates, but it does help to put that paper together if you want to go to a senior leader and say, this is what we're experiencing in the organisation, what could we do about it? And of course, we have other PDFs and information around reasonable adjustments and other things that employers can do. So we can help with people who want to get off the ground and want to talk to senior leaders about making the changes. We do have an awful lot of other resources as well that's out with CME and Work. You may be familiar with our Let's Chat tool, talking to managers about mental health. We have our It's OK to Talk National Day. It's usually in about February every year. We have our Walk a Miles. We are recently developing our new resource with It's OK to Talk as well, which helps with, once you've started a conversation about mental health, how do you continue that? What could you say? What are some things to think about? And recently for me, I delivered a session with Strathclyde University around with their pharmacy students, looking at how they make those connections with patients when they come into the pharmacy, and then if they have the right time and the right space to be able to have proper conversations about mental health, because a lot of the time it's not a good time for people, and acknowledging that and saying it's not a good time was a really, really helpful guidance and support. So there's lots of things on our website around that. And of course there's the e-learning. That's probably one of our biggest resources. Some of you may be familiar with that. It's about 6 modules that anybody can do for free, going through and working on disclosure and kind of an equalities training, but it is very well put together. I guess CME and Work, as I've said a lot today, is a big programme, and it might not be right for your organisation. And I've not said this, but CME and Work is completely free. It's free to anybody who wants to participate, and that's probably, I think, the thing for a lot of employers who don't want to spend lots of money on other wellbeing initiatives, such as Investors in People or Healthy Working Lives. This is a good start. There's it's accessible, it's free, it doesn't cost you anything. Of course, there is going to be the investment once you've identified some of those implementations. There may be costs associated to that, but to do the process and to make those improvements and to start the reflection of your organisation, you can access that completely free. But again, if it's not right for you, you can use the starter pack to self-assess. That's available on our website. You can run an OK to Talk or a Walk a Mile in your organisation. You can do the e-learning, as I said, and also you can just reach out to see me if you're looking to develop anything going forward. And that's actually why I'm kind of here today, is obviously the portal is an organised process, but if there's other things that you think would benefit in your organisation, CME is keen to partner with an industry to trial some of our approaches. We do work a lot, we have worked alongside the Law Society, I mentioned Strathclyde University, we've got loads of partners, but you know, all our resources aren't appropriate to them, and I think there'll be a lot of organisations who might be sitting listening to this presentation and think, oh, that wouldn't work for us and that wouldn't be appropriate. So I'll open up for questions in a wee minute around, you know, what could an improvement offer look like for you? What type of things is missing from CME that could be beneficial to you, or any ideas that you have, and we're welcome to have that discussion. And that's really why I wanted to come today, just to kind of kickstart that, to see what we've got, but where we're going or where we want to go. Of course, this is the final slide here today, so if you are interested in CME and work, it's a little short notice, I realise now, we are having a network event. So the network is attached to CME and work for anybody who's participating. We run quarterly networks where all employers get together and they discuss where they are in the process and any challenges. So we can have anybody there, from Police Scotland to small organisations to anybody who's part of the programme, and a lot of feedback from that is that people get the opportunity to talk to colleagues that are not in their sector and see what's going on. But also, ultimately, it's nice sometimes to hear that some of the challenges that you're facing are the same in other organisations, so you're kind of not alone in that respect. So it is on Tuesday, as if it's quite late notice, but if you're in and around the area, I'll drop the link into the chat function. You can sign up. We'd love to see you. It's a really good way to get introduced to CME and work a little bit better. And of course, the CME team will be available, and Rachel, who runs this whole process and is in charge of CME and work, will also be there, and will be much better and much more equipped than I to support you. But that'll take me on to a few questions if anybody has anything they want to ask, and of course that big important question around what else could we do to support employers, or indeed support your organisations or areas that you're working in to take forward an anti-stigma approach.
Wow, that's fantastic, Lindsay. Can I ask people just to put questions, preferably in the Q&A, if not in the chat, and I'll keep an eye open for them. Just talking there about industries and getting industries engaged, and I know you've got many industries engaged. Rural Scotland has a diverse amount of industries, and they're disparate, sometimes small businesses, but they're all part of a big industry. And I think of farming, of course, forestry, fishing, aquaculture, all micro businesses, but all part of one industry. Are there any of those industries in particular that you have engaged with, and talking maybe about how that happened, and are there others that you maybe think we need to engage with that we can perhaps help round this table? And as I said, others can put Q&As in the question, that'd be great. We'll pick them up. Thanks, Lindsay.
Yeah, I briefly mentioned that we've had a big partnership with the Law Society, which has been quite foundational in shaping CME and work. But of course, I appreciate lawyers' membership bodies. That's quite a specific area, and there's a lot of different challenges that go on. But we're particularly looking for rural, but also male-dominated industries. It's not an area that we've worked with, and it's something that comes up from a lot of our research around male suicide, and also our offer, does it attract an industry? So for example, construction or fisheries, as you mentioned, we're always interested to work with somebody who's already working in the sector, because of course we know the stigma piece and we know it, but you know your industry, you know what's going on, and you know the challenges. So that's why we're looking for a partner or someone to say, ah, that's rubbish, that wouldn't work. You know, that's about kind of doing it as a tailored approach and what could be beneficial, because a lot of our resources are created to be used universally, but we're trying to take that step a little bit forward. We've done a big universal marketing, we've done lots of universal, but we're looking on really honing that down and focusing on who's available and who has the appetite, because as we're seeing in the back of COVID, a lot of people are coming and sort of thinking, okay, how do we support employees? What does our business look like? What is our offer? Oh,
remind myself to put myself off mute. Let's see if we've got any questions. So we've got a question there from the Scottish Recovery meetings, and they're asking there, is there any pattern of engagement from sectors less or more, e.g. health and social settings?
Sure. There isn't really a pattern. We have about 115 people who are participating in CME work, but they're not all active. But we do have we are connected to some employers who are not doing CME work. So for example, the Scottish Ambulance Service, we've worked with them, but they're not in a place to do the full CME work programme, but we've done some training with them, we've worked with their mental health teams. So we can do soft touch with people. It doesn't necessarily have to be a big partnership or a big official partnership, but we do encourage people to do CME work because that is our main offer, and also it's something that we work very hard to get right and get that improvement methodology together. I know it's lots of different people come to us from lots of different organisations. I believe that in the past there was ScotRail we were involved with, and we also work with fizzy drinks companies, lots of different people, and I'm like, oh goodness, who else? But yeah, it's not necessarily one size fits all, and I think that kind of goes on to the next question. The toolkit does, if you've got a small number of employees with the survey, obviously if you've only got 5 employees, there's the idea that you won't be anonymous in that. However, there's other things that can be done there, a more open focus group where you can talk about, you know, the business case, and there's other ways to go about it. It doesn't necessarily have to be the kind of hard survey, and in that case the survey wouldn't be appropriate because we wouldn't be able to protect employees' identity, because it would be clear who says what, or their age and their demographic if there's someone identified. So the portal doesn't necessarily lend itself to very small organisations, but there's other ways that we can support. And again, the self-assessment could work across any organisation in terms of identifying those gaps. So yeah, thanks.
Okay, well, there's another, thanks for that. I think they answered the question from Fiona Thompson there, who Sport Mind Scotland, who deliver funded mental health awareness training to rural employers through Scotland. So that's maybe a good link there, Lindsay, to make after the meeting. We've also got a question, sorry I missed it, Katie, you were actually the first to put one up. Katie Malone from Kirkle, saying great presentation. So but there's also a question: how do you measure and evaluate your own impact in the business communities? Great question, Katie.
Yeah, really good question actually. So see, every year we have our delivery framework which sets out what we're going to achieve, and then we're evaluated by our partners at MHF. So they will reach out to the partners and people that we've worked with and measure impact. So we'll at the beginning of processes, again, if we've got an employer, for example, we'll maybe do a pre-evaluation and another evaluation, but just in terms of how we have been and what we are doing in it, and then again at the end. But all our evaluation is looked after by MHF, because that takes a little bit of it away. We're not marking our own homework in that respect. I know MHF is a partner, but they do it away from us, and they will talk to organisations that we're working with to see and measure our impact. But I will say, and as I covered at the beginning, we are working on the culture and the leadership and the big piece, and the things that are actually quite tricky to measure and also quite hard to get buy-in for and about. So it sometimes feels like we're up against it and we maybe not necessarily make headway in the way that we think. But there are other ways where people come to us and say, oh, you know, following a campaign, I disclosed to my manager that I had something or I wanted to share, and that from this campaign I've been able to do that. So it's the smaller, more anecdotal information that sometimes is the most powerful for us. But we are evaluated every year. We do a 6 monthly, it's posted on our website, and we do an annual review against our delivery framework to make sure that we're meeting our aims that we set out in our framework. So our big business plan document is with fairness in mind, available on our website, and it's running from 21 to 26. So we've got a few years to spread out the actions. Is there another? Oh, I think there's some chat in the chat that's relating to the previous presentation, which is good to see things still carrying on.
There is some chat in there just about running workshop with communities of interest rather than geographically defined communities. But there's an interesting part there, which is, I know it's a question for the last person, the last presenter from Hereward, but there's thinking of migrants and refugees in the Highland area, and well, in fact, all of Scotland, rural Scotland. We know ourselves that we've done work with migrants and refugees, and we've talked about Phoenix, which you mentioned, the Polish migrant workers. Maybe could you highlight a little bit about the work with Phoenix and the Polish migrant workers, and also maybe thoughts about how we can engage more so with refugees, migrant workers, and what we would call marginalised communities, the ones that were harder to reach perhaps for many different reasons?
Sure, yeah, that's a big old question, so I'll try my best on that one. I believe we've been working with Phoenix for a number of years, and again, they have done a lot of the work themselves with a little bit of support from us. So it's about giving some of our materials out supporting, but recently was introduced that they had developed their own champions, which is similar to our own model, or having volunteers. So it's about applying the CME way within other settings, building a bit of capacity. And I think that, as I said in my presentation, sometimes it's about being careful about connecting with groups who know the marginalised communities better than us. We obviously don't work with Polish people directly, but Phoenix do. So it's about making sure you get the balance between, you know, who are the players in the organisation, or who are the players in the sector, and who can we go to with that and support through them. It's things as well like getting things translated. That's a big thing. We don't have most of our websites in English, so how do we get some of our materials into Polish or into other languages? Or how do we make them more how do you make the language softer? Because, for example, what is stigma? That means different things, and even the word is pronounced differently to different cultures and different languages. So how do we go about explaining what we mean in that way?
Well, that's excellent. I'm just looking for any other questions. I'm not seeing any other questions at the moment, Lindsay. But if there are any other questions, just now is your time before I wind up to the next part of the meeting. I'll just repeat that we will be putting a little link in the chat with a link to a survey, a very, very short survey. We'd like to get feedback about our forum meetings so we can improve as always. But Lindsay, thank you very much for all of that. I think I'm right. So somebody's saying you did a great job, Lindsay. So well done there. I'd just like to say that thanks for that, but you are happy for your presentations to be shared afterwards, so everybody gets your contact details, of course, and also all the details there. And I'm sure lots of people will be interested in taking up your offer of reducing stigma in rural Scotland and all of Scotland, of course. Thank you very much, Lindsay. So Sarah-Anne, I think it's back to yourself. Just to say, do the next part, and we have, as I said, a little poll there. So over to you, Sarah-Anne.
Thanks. Apologies, my camera has gone off again. I feel you might need to make me the host, whoever is the host just now. That's why that problem's occurring. That's great, thank you so much. So I've just had confirmation that unfortunately Martin Malcolm from Western Isles is not going to be able to join us for because of his technical difficulties. But that does mean we've got time for any other questions or points of discussion that anyone would like to put to any of the, or either of the presenters or Jim or myself to conclude, I guess, before we get to the end of the webinar. So if there was anything else, then feel free to put that into the Q&A. I think several of the questions are being answered within there as well.
I'd actually like to ask Lindsay something, if that's all right. I'm going to put my,
go for it.
Okay, so Lindsay, I got asked a question in the Q&A that I think might be a good one for us to kind of talk about together. It was, let me see if I can find it. How could CLD workers within the local authority support mental health learning in the community for adults? I'm wondering if you have any thoughts on that, because I think that's a really, it's a really interesting one.
Yep. Sorry, it's CLD. I don't, and the acronym's not coming to me. Do you know what that stands for?
Community Learning Development, I believe. Community Learning Development.
Yeah. Okay. Yeah, it's not as an area I'm as familiar with, but we do have, we can have two, as I say, we work across lots of settings. We have an education piece, so there is things for local authorities to do in terms of working with schools and young people, and that's called CMEC Change. So we have that element of it. I know you picked on adults, but I just thought I'd highlight, use another way to have a wee look on our website as well from CMEC Change. I think that all our resources we try to make them quite universal. So we've got our health and social care resources on our website. We've also got a huge volunteer library, or it's on YouTube, and it's volunteers telling their story, and those could be used at meetings or played on international days such as, you know, Suicide Prevention Day, or indeed Time to Talk Day. So there's lots of resources and materials that could be used by anybody regardless of your role, and that's the approach we kind of try to take. You don't necessarily have to be a specialist, and that's what I say all the time. It's not about being an expert, it's about having those conversations, and also just recognising the different types of stigma, because the big one that everybody always gets or always flags to me is around self-stigma. What is self-stigma? What does it mean? And again, we have lots of fact sheet and information on our website around that, but it's just really, really good to distribute the materials and have small discussions in small groups with staff members or indeed with colleagues around what does this mean to you, and also what does it mean for the profession, because there's a lot of stigma around certain professions, working in mental health professions, particularly for nurses or support workers. I mentioned pharmacists earlier. Their mental health training is very, very little, and they were in third year when I had spoke to them, and they hadn't had anything before, but they're out in the community and they're dealing with people. You don't know who's going to come into the pharmacy or how to deal with them, and a lot of people were quite frightened about that. They know the diagnostics, they know the gout, they know the heart conditions, they know this, but the are you all right and what's been going on, you know, that type of stuff they really, really struggled with. So apologies, that was a bit of a long-winded answer. My answer really, just to sum up, is really around our resources are quite universal. So we've got different things on our website for different groups, community groups that are quite specific. But also, as I said, if there's anybody who's quite successful in the arena, I think it's always worth having a conversation with them and seeing if you can do something together.
Thank you. Yeah, I just to kind of second that, I think there are lots of resources out there. There is stuff out there. The difficulty is, how do we get adults to engage with it? You know, children, you have a kind of captive audience in school, don't you? Because that's part of the lessons, that's part of the stuff. And so when they're doing their PSHE stuff in school and talking about emotional well-being, as I said, it's kind of worked into the curriculum for excellence. It happens there all the time. But for adults who aren't in education and stuff, how do we get them to access these things? And it is quite a challenge. I think someone said earlier in the, I'm skimming through the chat, that it should be employers who make availability for, it should be the responsibility on employers to help out with training time and coordination. So the employer's responsibility to make sure that their staff can access these things, I think, is a really important one as well.
Yeah, I would agree with that. It's definitely about making the time, but also as well prioritising it, so it's not an add-on. You know, it's the thing, it's this training has to really become a space that's protected for people to do it. And someone has brought up in the chat there, what about Scottish Union Learning? And I've made some connections via Dan Henderson, who's worked a lot with, I think her name's Catherine, who leads Scottish Union Learning. So yeah, we're in discussion around how we take forward some of our CVing work stuff, but also as well some of our general resources. So yes, thanks for bringing that up, John. There'll be some things coming out in the next wee while, but that's it. We know we're not an island. We need our partners to go through that. But yeah, it's tricky. I think again as well, the leaders piece, I just wanted to flag that bit. It's really about leaders. If we don't have the buy-in from senior leaders, we can't get the rest. The rest won't come. They won't be interested. You need to have a vision, I think, as a senior member of your organisation.
Yeah, I just one more thing. I think you said there, you know, that it's not seen as an add-on. It's not kind of just all right, we'll tick this box and then our staff have done their mental health awareness stuff. And I think I'll go back again to the curriculum for excellence. One of the things that I think has been really successful in the years it's been running is, as I said, emotional well-being and mental health issues have been embedded in the curriculum. So it's not that they have a lesson on it a week just to tick a box. It's there, you know, at the heart of the curriculum, and so has influenced. And I see young people that have been through the curriculum for excellence are pretty aware of mental health things. They're pretty clued up on their emotional well-being and checking in with themselves and how they're feeling. And it's how can we get this level of awareness with adults, I think, would be a really interesting challenge.
That's great. I don't think there are any other questions that have come in the Q&A just now. Jim, was there anything that you wanted to reflect on from the themes that have come out today, I guess, in terms of maybe what's important to the Rural Mental Health Forum members as well before we finish off?
Yeah, no, thanks very much, Sarah. And I think, yeah, reflections are always good to do, of course. The first presentation really resonates with much of the lived experience that we've found and some of the research that's happened as well. So Support Mind Scotland, who run the forum, and I'm a Director of Public Affairs, Policy and Comms with that charity. We support about 1,800 people, mainly in rural Scotland, and the majority of our people, or sorry, not the majority, the main area that we are is in the Highlands. That's where most of our staff are. The other main area, second main area, is Dumfries and Galloway, which is equally a rural area, albeit we don't have the islands down there, but still rurality and remote rural. So some of that research highlighting the fact that the community is really important. I say it quite often, but people with lived experience, and the people with lived experience say this, and this is really important, look to be supported within their community before they get into a crisis. And there's also that part in rural Scotland, which is a bit different to urban, whereas that lack of anonymity, which I think was coming out as well, in rural areas makes it a little bit more difficult to present or disclose. So I think those are sort of important parts. Also from the research as well, mental health education for all. We've got Fiona Thompson here who runs mental health training and some free, I should say, places for that. Mental health is everyone's business. It's obviously the business of mental health charities and the business of mental health directorates. It's the business of CME, absolutely. But it's a business for everyone, because we can all do something and prevent people needing our services. That's an ideal world, of course, but there's nothing wrong with being idealistic, I don't think. We are tackling mental health stigma, and you know, Lindsay, nearly 20 years, and I will be joining you in Glasgow for the celebrations. So I'm looking forward to seeing you there. There's been great progress in that, but there's still great progress needed, of course. So Lindsay, you and all the team at CME, I was wearing a hat, I would take it off to you all. So maybe I'll bring a hat to do celebrations and take it off. You'll keep me right in doing that. So yeah, what also has come out in that research, and what we find as well, that people want bespoke services and support. I'm using those two words because they're kind of different and they're kind of the same. Support and services are really important, but every single individual with poor mental health or not poor mental health is an individual, and what works for some people doesn't work for others. Some people love getting into green space, great, more green space. Others need other things. Some people like art therapy, all that. So we have to really consider not just doing a one fit for all. I think that's really important, and I think that's been recognised in that research that we heard about at the very beginning. Better funding for resources, yes, but again, you know, there is a limit to government money, and the government pot has doubled in the last few years. But of course, there's great backlogs with all sorts of services, etc., due to COVID. So there's issues there. There is more funding in mental health. There'll never be enough funding for mental health, of course, and it will always campaign for more. But the fact that we can make it everyone's business, then we can all chip in and not just rely on Scottish Government, which is we'll keep pushing for that, of course, and NHS, etc. So it is the sort of holistic approach. I think is very important. Somebody saying that we're using mental health with a negative connotation. No, that's sorry if that's come across. Mental health and mental illness are two different things, of course, and we support both people. Having good mental health is equally good, of course, as well. So that's great. So good point, John Cairns there. I think I'll probably...
Can I just add something to that? Sorry.
Yeah, of course you can. Before I wind up. Yeah.
With what someone said there about mental health having the negative connotation. I have a really interesting discussion with my child and adolescent mental health students. Every year, every semester, we run this module, and I ask them to go away and ask people what words appear when they say physical health and mental health. So to go and ask different people what they think of when they hear the words physical health and mental health. And 9 times out of 10, people will automatically give positive things for physical health. They will talk about going to the gym, healthy eating, personal hygiene, blah, blah, blah. And very often with the term mental health, they will say depression, anxiety, stress, and these sorts of things. And they will come out with a kind of negative connotation. And it's a real challenge, actually, overcoming that that leaning. As I said, in our own research, when we were talking with the first question, we were quite, I was quite amazed, to be honest, of how negative the experiences were with regards to mental health, and how passionately people spoke about them. But as I said, one interesting thing is when we look at the findings, when the younger people are asked about mental health, the younger generation, particularly those in Scotland, will actually be more positive in their language they use about mental health. They'll talk about emotions, they'll talk about feeling calm, they'll talk about meditation and stuff like this. So again, this is part of my kind of my own feelings that those that have been through the curriculum for excellence have a better understanding of mental health. The younger generation, I think, actually, thanks to that stuff that's been embedded in the curriculum early on, have actually a better understanding of emotional well-being and what mental health is. So there's a bit of positivity for the future there. Thank you.
I think you're right. I think we maybe have to wait to see those generations come through, but I think we're already seeing that happen. I do get frustrated as well as mental health covering everything, you know, from anxiety to psychosis and suicidal ideation, etc. You would never talk about all the different physical health issues as well. And of course, there's that difference, as MWC2 says, which is, I think, might be the Mental Welfare Commission, that mental illness is something quite different to mental health, never mind the broad range of mental health and different mental illnesses. So yeah, I think we'll stop there. Can I just thank everyone for attending? Sarah-Anne Munoz, it was great to do a joint, Professor Sarah-Anne Munoz, it was great to do a joint meeting like this. We've had a great turnout, I think well into the 70s who have attended today. Scottish Rural Health Partnership shall be putting the recording of this today up on their website. We'll share that with the National Rural Mental Health Forum members as well, so everybody has the link, even those who haven't been able to attend today. The presentation, Sarah Munoz, will be shared as well, so that's fantastic, and we'll do that. So can I just say the National Rural Mental Health Forum, as I said, since COVID has happened, we've had online webinars, and I think this is the 37th. The 38th is on the 9th of November between 11 AM and 1, and it's regarding some great piece of work that's happening with CME as well on tackling mental health, mental illness. See, I'm making the mistake myself, mental illness stigma. So if you can come along to that, that would be great. It will be going up on our website later this week, ruralwellbeing.org upcoming events, and I'll give you the link. There's also an email for myself. If you're not involved in the National Rural Mental Health Forum, then drop me an email, and I'll just pop that there. There's my email. Just drop me an email. There's no cost. We encourage everyone to get involved in tackling rural mental health. And there's also just a reminder of the survey there. So if you have time to fill in the survey, take a couple of minutes, give us some good feedback, bad feedback. That'd be great. That's a great way of us measuring our impact and how we can improve these important forums. So thank you, everyone. And I think the rest of us will go back to the backstage, as they call it in Zoom. But thank you, everyone, and have a good rest of the week. Thank you.